we're going to go into a little bit about sort of conceptually the contraceptive calendars, things that you can and cannot do with contraceptive calendar data, and specifically PMA data. And once we've done those three things, we're actually going to kind of dive right into the coding part about how to manipulate and format the data from the format that it comes in to the format that you need to really be able to do analysis. And so once we've gone through all of those things, then we're going to break out into 2 rooms to go through a demonstration exercise of using the calendar data to create a survival curve. And we're going to do the same demonstration in both rooms, just one is going to be done in R and one is going to be done in Stata. So when we get to that point, you self-select which room you want to go into, depending on kind of which language you want to code in or watch the demonstration in. And if you don't mind, and if you don't self-select, we'll just randomly assign you to one. So we'll go through those demonstrations in the breakout room, and then we'll all come back together again for a Q&A session, and then finally have a conclusion with a little bit of a peek into the longitudinal data and what's coming next, and not just what we can do with the calendar data now, but what we expect to be able to do with the calendar data once we get the sort of next round of longitudinal data in. So that's what we have. Next slide, please. Okay, so this is me giving the presentation, the part on the overview of PMA. So just to give context for those of you who are not intimately familiar with PMA, and I saw some familiar names coming up, so some of you are, but for those who are not, PMA stands for Performance Monitoring for Action. And the origins of PMA were back in 2012 when the family planning community set a goal of 120 by 20, 120 million new users by 2020. And PMA was one of a suite of data collection projects that were launched at that time to help track progress towards that goal. We're funded by the Bill and Melinda Gates Foundation, and we're a survey project that collects data on women's contraceptive use and reproductive health. Right now, we work in 9 African countries and in India. We have at various points of the project included up to 11 countries at a time. And we work with partner institutions in country. It's usually the local university that's a partner PI, to conduct a household-based survey that focuses on contraceptive use and reproductive health. But we have also at times added modules on other areas of interest. So we've fielded additional work on abortion, on nutrition, water and sanitation, primary health care, and now a COVID module, all sort of fielded alongside our ongoing core family planning work. And all that data is available to the public. We are right now in the 2nd iteration of PMA, starting in 2019. And the big design change is that instead of doing a new cross-section every year, we actually revisit the same women. So now it's a panel. As an aside, we also refresh our lost panel households so that we can still generate representative estimates. So we sort of, in each round now, we kind of have 2 sets of estimates, one set of kind of longitudinal panel estimates and a cross-sectional estimate as well. And so, of course, the longitudinal data is very exciting because it allows for all different kinds of analysis. It allows us to follow individual women through life course events. So we can see how shocks, like, for example, COVID, might impact her family planning risks and opportunities down the line. So that's a very exciting design change for us. Next slide, please. So how PMA works. We start with a representative sample. It's a 2-stage cluster sample for survey nerds of the communities in our country. And in some countries we're nationally representative, and in some countries we're subnationally representative of a specific area or state. It's a randomly drawn household sample from the national census. And we basically just send our interviewers to those randomly drawn households to interview any women between the ages of 15 and 49. We hire and train resident enumerators, and I talk about that because I think it's quite cool. We work with women from the communities where we work, and we think that having resident enumerators is really helpful for building rapport and understanding the community context and the women that we interview, and consequently for keeping our response rates pretty high. And it's an investment in the communities where we work, which I think is important. The REs conduct the survey using a smartphone, and then they upload the data directly via a cloud server. I should also say, in addition to going house to house, we also go to service delivery points, which are family planning facilities in the communities where where our respondents live. So we try to get a mix of private and public and larger and smaller scale facilities. The facility sample is really designed to give us a sense of what the family planning service environment is for the women that we interview. So it's not really a national picture, it's really tied to the women. All the data that we collect is uploaded by the cloud server, it's cleaned, and then it's turned into data products. One of them are data sets that can be manipulated like we're going to do today. But we also produce briefs and dashboards, and we have a website data lab, which is sort of somewhere in the middle where users can go and kind of generate their own charts comparing, over time or across countries, generating their own charts. And then a final note is that the data is made publicly available 6 months after collection, which sounds like a long time, but is actually quite fast for a survey of this kind. And the idea behind that is really to make it so that the data comes out in a time frame that's useful for stakeholders and policymakers to act on it. Next slide, please. So I said we had a panel. We really actually have 2 panels. We have a household panel, and from that we get our population of thousands of individual women answering the female questionnaire, and that's actually the data that we're going to work with today. But we also have a panel of facilities, as I said, where we revisit the same facilities as well year to year to see how the service environment changes. And that's partly through direct observation of the facilities and interviews with facility managers, and also through client exit interviews in those facilities. And so we track those 2 panels independently, but it's also possible to link the data from the 2 and be able to talk about how they impact one another. So we can tie things like stockouts and see whether women discontinue or switch methods based on what's locally available. So that's the design. Next slide, please. So these are the countries where we currently work. And I want to pause and highlight this both because this is where we have data right now coming in. But I also want to take a moment to highlight who our partners are in each country. And I should probably have made that larger and more bold because I wanted to just say that, these are very much equal partners in this work. Many of them have been working with the PMA and have been PIs on PMA for 8 years or more and are very much the owners and the intellectual heart of the study as much as Hopkins or Gates Foundation ever is. I also wanted to note there's a little star next to Ethiopia on that list, and that's because the Ethiopia survey is a little bit different, and we're going to hear from Saffy a little bit later in this session, who will talk to data from the Ethiopia project. So I wanted to note that. Next slide, please. Just talk a little bit about how it's different. So the main difference is really the sample. The Ethiopia project does do a cross-sectional survey, but that particular sample and that particular questions were co-created with the government there to generate data specifically on pregnant women and maternal and reproductive health. So it's quite a unique feature. It's a panel of pregnant women rather than a representative panel of all women, with multiple follow-ups throughout the pregnancy and postpartum period. And so that allows the Ethiopia project to ask questions much more focused on the subjects here, on things like antenatal, delivery, vaccination, sort of more nuanced aspects of maternal and newborn health, whereas the other core countries are much more focused on women's contraceptive use and reproductive health. Next slide, please. So this is the contextual framework for PMA, and it's an incredibly complicated picture, but really the only thing I want you to take home from this is the main idea that women don't make decisions about family planning in a vacuum. There are lots of other factors. There are community norms and attitudes. There's how much power she feels in her community and her home. There are her healthcare providers. The service environment can limit her options or expand her options. And then, there's the fact that reproductive intentions themselves are just fluid depending on where you are in your life at that moment. And so there's a lot of academic work and measurement, and it's very hard to capture all of that. And so we're always trying, testing new measures and trying ways to sort of capture this complex picture a little better. So we've been adding a lot more into the survey to kind of capture all of that. And that's sort of less of an abrupt change and more of an evolution over the various rounds of PMA. We started out quite tightly focused on contraception, but over time and in response to demand, we've expanded the survey to capture more of these sort of contextual factors of women's lives and their households that are all part of that package that influences family planning. Next slide, please. So, as I said, we're asking a lot of new questions starting in 2019 on women's empowerment, economic empowerment. We ask questions about intra-household bargaining, about finances, who makes decisions about finances, who makes decisions about contraception. We ask a suite of questions on women's sexual and contraceptive autonomy. And so we're really trying to get more detail on those factors. And of course, the 2-year contraceptive calendar, which is the star of our show today, and what we're going to talk about and start getting used to. So all of this data is available on our website at pmadata.org, but it's also being housed and harmonized at IPUMS, who are really specialists in making data really accessible and easy to use for analysis. So I'm going to pass on now to my colleague from IPUMS, Devin, who's going to talk a little bit about IPUMS and what they do and how they harmonize data, and specifically what they're doing with the PMA data.
And thank you so much, Elizabeth. Hi, everyone. Thanks for joining us today. I'm Devin Christensen, like Elizabeth said, and I work at an organization called IPUMS, which is affiliated with the University of Minnesota Twin Cities. I'm the project manager of IPUMS PMA. So this is the project that harmonizes the incredible PMA data. And I'm going to let my IPUMS colleagues introduce themselves as well.
Hey everybody, I'm Matt and I'm a senior data analyst with IPUMS PMA. I work with Devin, but I'll be working on the R breakout session with you today, and looking forward to discussing it with you.
Hi everyone, I'm Nina Brooks and I'm a postdoctoral associate at the University of Minnesota, where I'm doing research with IPUMS PMA data on environment and fertility relationships. And I'm also helping out with the PMA Data Analysis Hub, which I think we'll talk a little bit more about later on in this session, and especially in our breakout room.
Absolutely. So next slide, please. So I'll take a step back and describe what IPUMS is. So IPUMS provides census and survey data from around the world, integrated across time and space. IPUMS integration and documentation makes it easy to study change, conduct comparative research, merge information across data types, and analyze individuals within family and community context. And we are entirely grant funded, so we never charge for use of the data. Next slide, please. So we don't just harmonize health survey data. We have a variety of microdata and also aggregate data that we harmonize, integrate. We have everything from US and international census data, labor force surveys, time use health survey, and some GIS land cover and environmental data. Next slide, please. So my work with the PMA data involves processing the data and making sure that the variable codes and names are consistent across time and country. And then we also systematically document each variable. So we look at the question wording, we look for comparability issues across time or across country. We document the universe of the question, basically describing the skip logic so you understand what your denominator is. We also create some calculated fields to help you with comparative research. And all of the work that we do allows you to create a custom data file in various formats. So you can get it, you can read it into R, Stata, SPSS, and SAS. You can download it as CSV. And the reason why it's really powerful to have a custom data file is that you only choose the variables and samples that you need. Next slide, please. So this is our website. So many of you went and registered with us in order to get access. So you have to register an account. We'll review your research description and approve you if your research description is appropriate for these data. So if you have any further questions about IPUMS PMA after this, if you go to our website, you can go to the support link. We have a lot of video tutorials, and we also have some previously recorded webinars. Next slide, please. This is the online data dissemination system. So this is where it's like an online shopping cart. You select your samples, browse through variables, and then you go through a couple simple steps to create exactly the data file that you're looking for. And in the breakout sessions, we will actually be demonstrating how to use this. Next slide, please. So I think I'll let Matt take over here.
Yeah, so as Nina, I think, mentioned a minute ago, to complement this data dissemination system, IPUMS PMA also launched a blog early this year. And we use this as a space to kind of spotlight exciting data topics in IPUMS PMA or to highlight newly released data. So most of the posts that you'll see on this page include code that you can use to reformat, visualize, or analyze PMA data, very, very much like what we're going to do in the breakouts today. But the blog usually just focuses on R code. We're hoping to include more Stata code in the future, but we kind of started with R. In fact, so later this month, right after PA is over, we're going to add a post to this list containing all of the code that we're going to go over in the breakout sessions today. And I think what we're also going to do is transcribe questions from the Q&A and actually write out our responses there. I saw in the chat someone was asking if there'd be a recording of the sessions. So yes, but we're also going to do this too. So I'm definitely happy to talk more about the blog in the Q&A if you have general questions about what we do there. But as one additional aside, one of the things we're going to be adding to the blog, I think by the end of May, is going to be a user certification course, which should serve two purposes. It's going to introduce newcomers to the IPUMS PMA data dissemination system. And then the second thing is that it's going to offer a certification upon completion. So definitely visit the blog or please get in touch with me if you have any questions about that user certification course. So next slide, please.
So I think, I believe Dana is up next.
Yeah. Hi, everyone. My name is Dana Sarnak, and I'm a PhD candidate at the Johns Hopkins Bloomberg School of Public Health, as well as a research assistant at PMA, where I've been working on the calendar for the past 4 years. So today I'll give a brief overview of the history of the contraceptive calendar in general, as well as within PMA. And I'll explain how the data is collected, what it looks like in the data set, how to read it, if you will. And I'll show some examples of what can be done with contraceptive calendar data, and also preview what can be done with PMA's longitudinal data and calendar data that will be coming in the next year. Next slide, please. So just some background on contraceptive calendars in general. Next slide. The first use of a calendar in the reproductive health field appears to have been the coding of contraceptive methods in the US-based National Fertility Survey of 1965. Other fertility surveys in Latin America and the Philippines used calendar-like approaches to record sexual and reproductive health events in the 70s and 80s. And the Demographic and Health Surveys, or DHS, began to incorporate a calendar module into selected surveys in the mid-1980s. And most of their surveys today include a 5-year calendar, which you can see a paper version of on the right. Next slide, please. In 2017, PMA piloted a 5-year retrospective calendar based on that of the DHS in a longitudinal panel in Uganda. And using what we learned from that pilot, a 2-year calendar was implemented into another longitudinal survey in Uganda in 2018. And lessons learned from both of these pilot tools informed the 2-year calendar that PMA is currently collecting in their longitudinal panels that are in the field in the 8 sites. Next slide, please. Currently, the PMA calendar is populated by the interviewer using certain questions from the survey, including records of all pregnancies in the past 2 years, their durations, their outcomes, and the pregnancy wantedness status, as well as information on current and recent contraceptive use in the past 2 years, including method type, duration of the method, whether the method was stopped or discontinued, and if so, the reason for discontinuation. Then at the end of the survey, the interviewer is asked to go through any months in the past 2 years that are not accounted for with the respondent, filling in a 24-month calendar with a drop-down list of the woman's status, including if she was not using at all. And the interviewers utilize a visual aid in this endeavor. Next slide, please. So this is what the contraceptive calendar looks like in real life. And I like to show this image of how the calendar is filled out during the interview to help people understand what we later see in the data set. So here you'll see about a 2-year calendar starting at the interview month, which in this case is October 2020 in the far left. And it goes back through 2018 on the right. And column 1 on the top has notation that corresponds to a woman's reproductive status, which includes pregnancies, births, or contraceptive use or non-use. And column 2 below column 1 shows a discontinuation code that signals a reason for discontinuation for when contraceptive use was stopped. So here we see that this woman was using injectable, which is the method for code 5 from January 2018 until June 2019. In June 2019, you see the code 3 in column 2, which indicates that she stopped using because she wanted to become pregnant. Then the woman was not using any method for 1 month in July 2019, notated by the 0. And then she became pregnant in August 2019, notated by the first P, and then the following 8 or 9 Ps, and she gave birth in April 2020. And since her birth, she has not used any contraception, which is shown by the 0s. So if you can just remember what this 24+ month letter sequence looks like in column 1, you'll see that the contraceptive calendar string variable in the data sets that we use are essentially the same thing. Next slide. So here I'm showing you that. This is a screenshot of real contraceptive calendar data, the string variables from PMA data sets, so similar to what you'll be seeing today. And in row 24, you'll see exactly the calendar from the prior slide, just in the form that you'll find it in the data set, with the months separated by commas, but the rest is the same. So again, you read the calendar from right to left in terms of chronological time. We see that she was using injectables for many months before stopping for 1 month. Then she got pregnant, had a birth, and then was doing nothing until the time of the survey. So now you know how to read these calendar variables, and the respondents and their calendar histories shown in the rows below should make more sense. Of course, once you have what all the method codes are. And in demography and family planning research, we may be interested in many of these episodes that the calendar data can create. And what do I mean by episodes? Next, Laura, please. So we may be interested in the length of time of any one episode of use. So in our prior example, the length of time she used injectables before stopping. But we may also be interested in how long any use or by method women use before stopping. Next. We may also be interested in episodes of pregnancies. So the length of pregnancies or outcomes of the pregnancies. Next. We may also be interested in episodes of 0s, for example, in the case of postpartum family planning that I've highlighted with the pink box. So we'd be studying how many 0s or months of non-use come after births until women adopt contraception. Next. Or alternatively, how many 0s after stopping a method does a woman become pregnant? So there are a lot of research questions that calendar data can answer. Next slide. So let me just show you some examples from the literature. And of note, the following examples are using mostly DHS calendar data, as it has been the prime source of calendar data in the past. But we are doing and hoping to do more analysis with the PMA calendar data in the future. And we hope that other people use it, so hence this event. Next slide, please. The most common utilization of the contraceptive calendar, at least historically with DHS data, are calculating discontinuation rates of contraception, specifically 12-month discontinuation rates. So on the left, you have the DHS 12-month discontinuation rates for Sierra Leone. And these are in most of the DHS reports that are published these days. And you can see that this is defined as the percentage of episodes discontinued within 12 months, according to the reason for discontinuation there at the top, and by the specific method as the rows. Next. So you can see that the overall 12-month discontinuation rate for any method is 34.5, which is about normal. 1/3 of all episodes of contraceptive use will be discontinued in the first year. And you can see how that varies by method and reason. Next. Pills and injectables have the highest discontinuation rates in the first year, around 42%. Next. And implants have a lower discontinuation rate in this population at 17%, and that makes sense given short and long-acting methods. And in terms of discontinuation rates by reason, there are a lot of women discontinuing for desire to become pregnant, around 9%, and about 16 due to side effects or health concerns. Next slide. So I wanted to show you briefly that these discontinuation rates come from a type of survival analysis that you'll be doing later in this webinar with the PMA data. So without going into too much of the statistical methods of survival analysis, discontinuation rates come from these type of Kaplan-Meier curves that show the probability of survival on the y-axis over time on the x-axis. And this is using DHS data from Zambia. So in this example, the 12-month discontinuation rate for the injectable, which is the blue line, would be the inverse of the probability of survival at 12 months. So I've added in a black line at about the 12-month time point, and we can see that the probability of survival of injectable use at 12 months is about 67%. Therefore, the probability of discontinuation or the discontinuation rate at 12 months would be 33% in Zambia. And you can see that the discontinuation rate for withdrawal in Zambia would be higher, the red line, maybe about 58% or so, and the discontinuation rate for the green line, the implant, would be lowest, probably around 15% or so. Next slide, please. And one of the reasons for discontinuation is due to method failure, meaning that a woman becomes pregnant while on the method. So speaking of method failure, this is how we get a lot of data on how effective methods are besides clinical trials. And this graph comes from a big study that I've cited on the right that uses multiple countries and the DHS contraceptive calendar data to create global 12-month contraceptive failure rates. So I invite you to look at that. But they looked at what kind of women were more likely to experience failure and across which methods. So this graph shows the 12-month failure rates and how they vary by method and age. Next slide, please. So something else I wanted to show you is that the type of analysis that will be able to be done with the upcoming phase 2 of PMA data, when you'll have basically 2 calendars from 2 waves of survey data from the same woman. And you'll be able to really utilize the calendar to see how baseline characteristics influence subsequent contraceptive use dynamics, whether that be adoption or discontinuation of contraception. Next slide, please. So here you can see the 2-year calendar we've created in year 1. I think back a slide. Oh, maybe we're missing a slide. Okay, sorry about that. So I guess I can't show you the actual, how the panel design overlaps the structure of the calendar, but these are the types of analyses that you will be able to do with longitudinal data and the calendar data that we'll have when PMA phase 2 come out. So this is from a study that uses those panel surveys in Uganda when we were piloting the calendar that I mentioned in the beginning of the presentation. So here we used characteristics at baseline among non-users to see how they influenced the time to contraceptive adoption. And here we were interested in seeing if a woman's unmet need for contraception at baseline predicted adoption of contraception, as well as if a woman's intention to use contraception at baseline influenced the time to her adoption. So on the left, you'll see Kaplan-Meier curves for the probability of time to adoption in months by unmet need. And unmet need wasn't a great predictor of adoption, though those with no unmet need were slightly more likely to adopt contraception over the time period. However, on the right, you'll see that a woman's intention to use contraception at baseline was very predictive of whether she subsequently adopted over time. And that's the solid red line compared to the dash. So when PMA's phase 2 data comes out, these are the types of analyses that you will be able to do with the contraceptive calendar. Next slide, please. So I've shown a lot of things in very little time that can be done with the calendar, but I thought I would just mention some of the limitations. And most of the limitations in the calendar are based on recall bias. The calendar asks respondents to report on the start and stop dates of prior pregnancies, births, contraceptive use, going back several years. So it's really a lot to ask of people. So I did want to mention some of the work that has been done to evaluate the quality of calendars in general. Next slide, please. So there are two main ways to assess calendar quality. You can compare retrospective contraceptive prevalence rates tabulated from the calendar with independently estimated current status contraceptive prevalence rates from a prior survey. And that's what this report does for 67 countries with DHS data. And I can't go into all the findings, but the calendar quality really varied by region of the world. And often where calendar quality was low, the contraceptive calendar seemed to underestimate contraceptive prevalence rates compared with estimates from a prior survey of the same time period. So calendar quality is usually lower for shorter acting methods versus longer acting ones. So there is some evidence that in certain contexts, the calendar does suffer from some recall bias. Next slide. And another way to examine calendar quality would be by comparing calendars of the same women over time. So if you have longitudinal data and calendars, you could compare what was reported in the calendar and a reference survey to see if the individual is reliable in their reporting. And there have been a few studies that have been able to do this, and I'm showing these two studies from Bangladesh and Morocco. And they found that the calendar had pretty good quality on the individual level. But these studies are now dated and very specific in their geographies. So I just did want to mention the sort of data quality issues that the calendar comes with. And that's it.
Great. Well, thanks, Dana. The next part of the workshop, we will be explaining conceptually what we are doing to the data from the format that Dana showed us in the comma delimited strings, and what we're going to be doing with that data in order to use it. So there are multiple ways to format calendar data, but the way we've chosen to introduce it today is a pretty straightforward to reformat it into long format. And this will be every observation is a person period. So we'll see the same person multiple times and they'll have multiple rows. So I'll be going relatively quickly over this next session because it's mostly a primer. We are just introducing the functions and conceptual ideas of how the data are changing. And we'll go over it all again in the breakout sessions. In that way, you can see what we're about to do, and then in the breakout sessions, you can follow along if you would like to. And we've posted R and Stata code ahead of time, and I'm just going to drop that link in the chat. If anyone would like to go and download that code now. Next slide, please. So what we've designed as an example for today's workshop is to have everyone be able to create this, this survival curve, very similar to what Dana showed us. This is a Kaplan-Meier survival curve of women using all methods in Kenya, women who were surveyed in 2019. So you'll see that this is the percent of women who are still using family planning over the course of 36 months. Oh, sorry, next slide, please. All right, just to kind of hash over the details that Dana already shared with you. So it reads from right to left chronologically. It's comma delimited, and that's really important for the way that we're going to work with the data in the stats programs. And so the calendars that are currently up on the IPUMS website and on the PMA website have different start months. So we will be, or just covering a different periods of time. So we'll be using the Kenya one. So that'll start in January of 2017 and go to the end of 2019, or 36 months. Next slide, please. So I find it really helpful to look at what the data look like. Dana already showed you an example from Kenya. I also wanted to show an example from Burkina Faso. I took a few records from some of the women just to show you that some of the PMA calendar variables have some leading commas, just so that you're aware that those kind of represent some future months. And R and Stata will deal with those a little differently. But as you see, it's a variety of contraceptive methods switching, pregnancies, fertility behaviors, and it's in a string. So next slide, please. These are the codes that represent the contraceptive behavior or fertility status in each month. This list is available on our website for your reference. So as I mentioned, on the IPUMS PMA website, we systematically document every variable, and every variable has a codes page so that you see what code corresponds to its value. Next slide, please. Okay, so the very first step that we will be taking today is to divide that singular string variable into wide format. So we're going to split into the 36 months. And we're going to signal to R or Stata that it should split wherever it sees a comma. And so it's going to create 36 new variables. So next slide, please. So after either the split command in Stata or the separate command in R, I just did a zoom in on like it'll create all these new variables for me and number them according to the month. And also Stata, what Stata will do with those, the series of commas at the beginning, it's going to still create a few variables for us, but they will be empty. And then Matt, you can let me know what the R does with those.
Yeah, R does something very similar. It's just that we're going to be explicit about padding the placeholder values on the left-hand side rather than the right. So that's really the main difference.
Excellent. Okay. So next slide, please. So in order to switch from the wide format where every row is still an individual woman, the analysis or the graphing that we're going to be doing today, we want to change it so that it's in long format. So we want to have just one variable that is the time variable or the month, and then another variable which represents what fertility or contraceptive behavior the woman was taking in each of those months. So it's just going to be transposing. And then So we'll have 36 observations per woman. So next slide, please. Okay, and thankfully, both Stata and R have a singular function that will do all this heavy lifting for us. So reshape in Stata and pivot longer in R. So this is going to bring us from the person observation level to the person period level. Matt, was there anything that you wanted to say on this slide?
No.
Okay, excellent. Okay, next slide, please. So just in case we have a variety of disciplines or statistical experience, maybe I should just take a step back and talk a bit about what we mean by survival analysis. So we're talking about a statistical approach that analyzes the duration of time before an event occurs. So this involves the observations in the sample all starting with the same status. So in the graphs that Dana, Matt, and I have shared, we're starting with a sample of women who are using contraception in that first observed month. And then we follow them over time to see who is still using over time. So we won't be covering this topic today, but having the data in this long format also allows us to do some statistical regression. For example, I'm working on a paper right now where we're linking NDVI information from each month to see how the agricultural season is affecting women's reproductive choices. So you might want to be estimating how the woman's context at each month is affecting her decisions. So you can see this is a really powerful approach and a really flexible data format. It's important to note also that this survival curve is not showing women who have failed, and we're calling fail when she stops using family planning. We're not counting her again if she stops for 1 month and chooses a different method. As soon as she is not using family planning for a month, she drops out of that curve. Okay, great. I think that's it for this slide. Next slide, please. Excellent. So there will be a little bit of recoding and kind of massaging of the data that we'll do before we can get to that graph. So first, in the Stata group, we'll be doing a bit of converting those string variables to numeric, which will then let us be more flexible with how we're creating our is she using family planning now? And then Matt, anything to say on how you'll be doing this in R?
No, except to say that on what you don't see here is that we're going to be introducing a package called Survival that's going to help us with some of these reformatting tasks.
Oh, actually, that helps remind me. On the link that I shared in the chat, Matt has listed each of the R packages that you'll need to make sure that you have downloaded and loaded into R when you're working in the breakout sessions, if you'd like to follow along. Excellent. I've done a little bit of R and oh, thank you, Nina, for posting it again. And that is definitely key. All right. Excellent. I think the next slide, please. Excellent. So after all of those little steps, then we can, in Stata, we specify what the parameters of our survival analysis are. So I'm first going to tell Stata that month is the time variable that I'm interested in. And then I'm telling it that the variable person ID is telling it which observations to group together because they're the same person. And lastly, I'm telling Stata that I'm considering a failure to be when the woman is not using family planning. So if her FP use is 0 rather than 1. And then after I've told Stata to do that's what I'm saying is my analysis, then all I have to do is say STS graph. And one other thing that we'll go over in the breakout sessions is that I'm also going to need to tell Stata only look at women who started the very first month using family planning. Otherwise, the graph will get a little strangely shaped if you're graphing on women who are not using family planning in the first month, and it looks like going to be the straight line down because they all failed in the first month. So that's another thing to keep in mind. Yeah, and then anything else, Matt?
Yeah, so what I put here looks exceedingly easy because we're only going to be using the base R auto plot function. There are a lot of different ways to make a survival plot in R. We're going to kind of take the shortest, clearest version, but there are definitely more options. Before we get to that point, again, we'll have to do some cleaning on the back end that I haven't put here because it's a bit tricky. But we'll cover all of that before 10:10 this morning.
Excellent. Okay, so I think that should be enough of a primer to lead us all into the breakout session. So I'll turn it over to PMA folks to help us transition into breakout sessions.
Okay, so you should now have an option to join a breakout room, hopefully at the bottom of your screen there. And you just choose between whether you prefer to be in the R room or the Stata room, depending on what you want. And if you don't mind at all, then you don't have to choose and we'll just randomly assign you. So now is the time to go ahead and do that, please. Sounds like some folks are not seeing the options. I don't know, Brian or Laura, if you can help us with that. Yeah, it sounds like a lot of folks are not seeing the options. I'm trying to assign people as they're requesting, but.
Looks like we have about 30 people, 29 people who haven't chosen a breakout room yet. So we will go ahead and assign.
I think some of those folks are not able to see the options. I'm not sure why that's not coming up, but
yeah.
Anyway, I'm assigning people who are putting requests in the chat.
Okay, thank you.
Sure.
It looks like we still have a handful of folks who have not been assigned, and I don't see a request in the chat as to which room they would like to be in.
Okay, for those folks, I'm just going to go ahead and assign randomly.
Actually, those folks who have not been assigned, if you have a preference, please indicate in the chat. Otherwise, we'll just randomly put you in a room.
Did we move Danny Bahonik
Yes.
to R? Yeah, okay, good. Okay. Okay. I think everybody's in rooms now, Laura, but I'm not sure how I get to the room, which is a problem.
Which room are you in?
Stata.
Stata?
Yeah, I don't see myself to assign.
I just did it.
Thank you.
I think I did it. I'm trying. There.
There we go. Thank you.
Okay, welcome back, everyone. Looks like everyone's starting to filter back in.
So before we move to the Q&A, I did want to remind everyone that this webinar is being recorded, and so you'll have access to all of the whole webinar, so including your breakout room session, as well as the other breakout room session that you didn't attend, if you'd like to attend that one or watch the recording of it. So at this time, we just wanted to give, we've gone through a lot today. So in terms of content and coding, and so we wanted to open the floor for Q&A. You can raise your hand, you can put the question in the chat box, you can come off mute, and we will try to answer your question.
Maybe in the meantime, while people are thinking of their questions, to just reiterate a couple of the questions that came up in our session about just, can we contact you, and where can we find the syntax? Just in case those questions came up in both sessions or didn't come up in both sessions.
Okay, So I see some questions. Sorry, Elizabeth, did you want me to
Yep, go ahead.
go over the ones that came up in our group?
Well, sure, actually, but why don't we go ahead and answer the questions that have just been posted? I was just sort of saying we could reiterate that while we were waiting, but now we have actual live questions.
Okay, so I see one question: are there other modules that have time series data that can be used in long format? So I think if this is in relation to PMA, I believe that this would be the only type of module that we have like this. I'm not sure if Elizabeth or Sally, or actually anyone at IPUMS has an idea for that question.
I wanted to mention that the migration history data that was available for the most recent samples is also recall data, and we have a pretty lengthy blog post up now at the Data Analysis Hub about reformatting that, basically going through a lot of the steps that we went through in the breakout session. So I would encourage people to take a look there.
And I would just add that it's not the full calendar the way we've been discussing the module today, but there is also other family planning recall data in samples without the calendar that can be used to construct a longitudinal record for a shorter amount of time. And I believe at some point we'll have some demonstration of how to do that on the blog as well.
So I see a question. Are there any published material on calendar data from PMA? So I can put in the chat a few studies that we used with the Uganda pilot longitudinal calendars that I mentioned in my presentation. And but the phase 1 data is literally, less than a year old. So I think quite a few people are probably working on papers now, and we invite you to do the same. It's very new. So and that's really what this session was about. But I will put a few of the papers that we have come out from prior surveys with PMA. I see a question from Samuel asking about linking other variables, demographic and household with the calendar. Definitely, that is something that we often do with calendar data. We are interested in maybe discontinuation or adoption rates by certain demographics. So age, residence, wealth, all of those kind of things you will be able to link with a woman's unique ID to her various demographic and household characteristics. I don't know if IPUMS wants to talk about when would they do that in the data extraction?
Right, yeah, so we, in our breakout session, I just add a couple of variables, but all of it should be linked with the woman. There's no merging that you have to do. Much like when you download data directly from PMA, it's one data file. But the difference with IPUMS is you just have to specify which variables you would like. So yeah, absolutely, that's definitely possible.
I see from Kristen, with the new panel data, can you look at time for changes in marital status or sexual activity and link them to the calendar? Yes, you would be able to do that. I think it would take a little bit of complexity in the coding, but if you have anything that is, you have dates for anything. So in PMA, we do ask about how long have you been married? And I believe there are sexual activity time-sensitive questions. So if you have dates for, or any other variable, you can also line those dates up with the calendar variable, because each month actually refers to a specific month in time. So you could potentially look at marital status or sexual activity. I think it's beyond the scope of the webinar today, but it's definitely possible, just because they're all bound by dates and that information that you would have in the data set. So yeah, there's a lot you can do.
Great. I'm actually just going to jump in here because we do need to go to the sort of wrap up and listen and hear from Sally. But I do want to say we are going to, any questions that we didn't get to answer here, we're going to try to follow up with a blog post covering the questions that we didn't get. So if you have a pressing question, please continue to put it in the chat, and we'll try to make sure that we get to all of them after this. Thank you, Dina, for managing that. I think it's time to move on to Sally.
Great. Thanks, everybody. So my name is Sally Saffy. I'm an assistant scientist with PMA. And today we have focused on contraceptive calendar data, which, as others have described, it collects the retrospective data on contraceptive use. So we're asking women about the past. But as others have also already explained, PMA collects prospective studies in which we follow women and collect data related to reproductive, maternal, and newborn health over time. So during the next couple of minutes, I'm going to review the longitudinal study designs for PMA. And just a quick note that I'll use the terms longitudinal and panel interchangeably. And then I'm also going to talk briefly about the upcoming schedule that PMA plans to release the longitudinal data to users like all of you. So next slide, please. So you've seen this slide before today when Elizabeth presented it, but this reviews the PMA panel design. So PMA follows women of reproductive age in order to collect data on a variety of topics, including contraceptive dynamics. So under this design that's shown here on this slide, women are enrolled and followed for two years with interviews at this panel enrollment time about 1 year later, and then again about 2 years later. The exact timing of these surveys depends on the PMA country, but generally PMA started phase 1 or the panel enrollment in late 2019 or in 2020. Of course, there's also this panel of SDPs that Elizabeth talked about. So we follow both women and SDPs for a couple of years. As a reminder, the PMA countries with this design are Kenya, Nigeria, Burkina Faso, DRC, Rajasthan in India, Cote d'Ivoire, Uganda, and Niger. And again, remember that this design for the women, we're following women of reproductive age. And we are going to release the data sets that contain information about women at these different points in time through the panel, which are about a year apart. And if you download these data sets, you would be able to link women across the data sets with a unique identifier. Next slide, please. So this is the panel design for PMA Ethiopia. Again, Ethiopia is a little bit different from the other countries. We follow women, but we're following women who are either pregnant or very recently postpartum. So that study design is a little bit different in terms of just who we're following. And then we follow those women through 1 year postpartum. So these data from PMA Ethiopia that we collect help us understand health and care seeking of women in Ethiopia from pregnancy to 1 year postpartum. And we will generate data sets that will be publicly available that include information about women when they enroll in the study, another data set about them at 6 weeks postpartum, at 6 months postpartum, and 1 year postpartum. So each of those data sets is separate, but you can link women across the data sets again with that unique identifier for each respondent. Next slide. So across PMA countries, we have or will soon have data sets that follow these women over time that I just described. As we prepare our data, users can request data sets. So if you were to go to the PMA website right now and register for an account and request data. For PMA Ethiopia, we have both that baseline survey of pregnant or recently postpartum women and women when they're 6 weeks postpartum. That data set is available now. That is what we have in terms of longitudinal data sets where we have multiple data sets for the same women over time. But a year from now, we'll have a lot more available. So in spring of 2022, we'll have both phase 1 and phase 2 following women of reproductive age for Burkina Faso, DRC, Kenya, and Nigeria. And a year from now, we'll have that all of the data for that first cohort of pregnant women from pregnancy through 1 year postpartum in Ethiopia. And IPUMS also releases the data. You'll recall Devin went through the process of manipulating the data for the IPUMS website. And so basically on the PMA website, you can download the entire data set. IPUMS, you can get smaller snapshots of the data, but you can expect all of that in the spring of next year. So in order to help researchers like you to access and understand that longitudinal data, we are planning to hold another webinar or another PAA side event webinar next year that will focus on that longitudinal data. I think that we can probably send that information to everybody who signed up today, so just stay tuned. Next slide. And I think we just have a few seconds to go through an example of what you can do with longitudinal data. So this slide shows contraceptive uptake during the postpartum period among women in Ethiopia. And so we didn't use the contraceptive calendar to generate this, this figure. We actually just, women reported about the specific date that they started using contraception as we followed them through their first 6 months postpartum in Ethiopia. And we generated the Kaplan-Meier failure function of contraceptive uptake. And you can see that we're looking at contraceptive uptake by the pregnancy wantedness. So that the pregnancy that the woman just had, whether she wanted it then, later, or not at all. And you can see differences in contraceptive uptake in that postpartum period. So we just have time for a tiny little taste of what you can do with the longitudinal data, but more to come next year, hopefully at our next event. Next slide, please. So that's it. We hope that you have enjoyed this event and gotten excited about using PMA data, whether that's the contraceptive calendar data or the longitudinal data that will be released shortly. And we hope that you continue to use, analyze, and publish with PMA data. Thank you so much for attending. And if you have any questions, feel free to reach out through the links that are shown on this slide, through the IPUMS website, and we'll be happy to talk with you further. So thanks, everybody.
Thank you so much.